It's pretty involved, and actually we do it in Massachusetts in partnership with the ACC. So there is a big national registry that the ACC supports called the National Cardiovascular Data Registry. Actually over 1,000 hospitals in the US participate in this. In Massachusetts, it's law to participate in the registry. As a result, we submit, it's a lot of work, submit incredible amounts of data on a data collection form that the ACC utilizes, both to Massachusetts and to the ACC. And then there's a big statistical operation to make sure that there is an adequate risk adjustment model that can, account for risk differences between patients. On top of that, because some of the variables, there's potential gaming, some of the outcomes aren't incredibly necessarily clear, we have volunteer physicians, I'm one of them, that go twice a year to the School of Public Health at Harvard, and we adjudicate centrally some of the variables like cardiogenic shock, other influential variables. These are interventional cardiologists volunteering their time to adjudicate it to make sure that the risk adjustment is fair and done in a correct fashion. Yeah, I think it's a great point that it's a broader issue than just in the cardiac field. The cardiac field happens to be on the leading front of public reporting. So we have the best data in cardiac surgery and in coronary intervention out of, I would say, any procedural field in medicine in terms of measuring outcomes. And that's why public reporting has come first in our fields. We don't have public reporting for spine surgery. You don't have public reporting for colon cancer surgery. The data aren't robust enough to be able to do that. And so even though there might be a goal to have those be done, certainly by policymakers, there's just a feasibility issue right now. And so now that we're on the leading frontier of it, I think it's our field's responsibility to make sure that we get it right, and so other fields that follow afterwards can learn from any mistakes that we've made in the process. And I'll say that Massachusetts and New York, Washington followed really just this past year. I think that these are two states that have really led the country in terms of public accountability, in terms of patient advocacy, and those are why we've come first. I don't think other states have decided systematically to come together and say, no, we don't want to do that. It's more that they've just lagged a little, but many states are moving in this direction. I would think that if the current sort of projections would move forward, that several states would adopt it in the next few years. There's a little bit of a red state, blue state thing in terms of this, and you can imagine that these types of things, public reporting, would be more prevalent in states that are a little bit more liberal. Yeah. Yeah, I think the results suggest that if you do it, you got to do it carefully. So I don't think it says one way or another that public reporting is a good thing or a bad thing. I think it raises concerns about some of the negative unintended consequences of public reporting. There are benefits. I think that anybody who practices in a public reporting state would probably tell you that procedural care is probably better because of it. And so now how do we keep the good aspects of it while mitigating the sort of the negative unintended consequences? We can learn from that. We can iterate on it and how we perform it, and then study it again. But I think other states should look to it and not jump in full force and sort of feet first without taking a good look at all the ways that they can mitigate the risks associated with it.